admissions. Now, obviously, we'll never get to 0 avoidable admissions, but that's what's at stake here. Next slide, please, Helen. So this is a bit more local. This is a study done 2017, 2018, looking particularly at avoidable hospital admissions in Australia, and also the disparity between avoidable hospital admissions in the Aboriginal and Torres Strait Islander people versus other Australians. And we can see here, especially in Western Australia, the rate of avoidable hospital admissions. This isn't just heart failure admissions, these are ones deemed avoidable, is about 4 times higher among the Aboriginal community rather than other Australians. So a lot of ground to be made up there. And in general, that rate is similar to what we've seen in Europe, around 60% avoidable admissions. So again, part of the problem is that the early symptoms of heart failure decompensation in the community are quite vague, not very specific. We're all familiar with these: dyspnea, orthopnea, paroxysmal nocturnal dyspnea. Again, very vague, and patients tend to suffer with them for days to weeks before they seek medical attention. The signs again, next slide please, Helen. The signs again aren't overly specific and present quite late. So again, these things, and they often take skilled physicians, skilled nurses to identify them. When we go on the next slide to look at the sensitivity and specificity of some of these signs, you can see that the problem is compounded a bit. Next slide, please, Helen. So here we can see the sensitivity and specificity of some of the common findings of heart failure. And again, with any clinical exam, it's never going to be overly specific or sensitive, but when especially rural and in community practices, we're depending upon these, as I'll show later on, we're flying blind a little bit. So again, we can see actually the disparity between 66% sensitivity for shortness of breath, not specific at all. Orthopnea, again, subjective, but also not sensitive. But we'll go into this in a bit more detail on why it doesn't work later on. So go to the next slide, please, Helen. Trying to make up some time here, sorry. So we have to look at what causes these decompensations. And if I was to, I suppose, do a quick poll of the audience and what you would think causes decompensation, these are the common answers we get: excessive water and salt intake, fluid restricting all these patients out in the blistering Australian sun. Non-adherence to treatment is always an easy one to pin on the patient. We don't have to look at ourselves and say it's non-compliance or non-adherence. Excess alcohol and drugs, of course, is a rising problem, unfortunately. But again, we have to dig down into the data here and look at what is actually causing these admissions, what's avoidable, what's not avoidable. Again, you're not always going to be able to avoid these things, but some of them we can. So next slide, please, Helen. Again, unfortunately, I'm working without some of my presenter notes here, but essentially this is a HEFTOS study that was done in Europe back in 2020. It was done across 10 different countries, most of them in Spain. So it was a multi-center prospective trial. And they looked at patients who were presenting to rural community GPs with what they deemed a heart failure decompensation. So they essentially identified that as unintentional weight gain of 2 kilos or worsening heart failure symptoms. And then they tried to dig down and see what was the precipitating factors that had, led up to this admission. And then they followed the patients for 30 days to see where they would end up. Essentially, when you dig into this data, you see the 2 biggest causes they found in Europe, and it's probably similar enough here, is respiratory infections, with a lot of those patients going on to need a hospital admission. And the second most common cause precipitant was rapid atrial fibrillation. So also in this data, what was also interesting was that the mean time from symptom onset to presentation was actually about 9 days. So, access to healthcare as well and patient education is really key here. We're losing about 9 days from patients realizing something's off, something's wrong, they're not feeling right, to them actually being seen and assessed by a practitioner. And as we can see, in some of these cases, 60% of the patients are going on to be hospitalized within the next 30 days. Now, obviously, this doesn't account for patients who are not engaging with their community supports at all and are just presenting straight to ED. These patients, we're engaged with community services and GPs, and we're presenting there first rather than just going straight to ED. But I suppose the important takeaways here with all these kind of what you would consider, avoidable respiratory infections, when our vaccination rates are so low, and atrial fibrillation, again, we can target a lot of these for intervention early. So next slide, please, Helen. So this is the meat of my presentation. I know I'm preaching to the choir here a little bit about managing heart failure in the community. When I was to ask you how we would monitor for heart failure in the community, a lot of you would say daily weights and self-reported symptoms from the patient. But as we see on the next slide, it's just not effective at preventing decompensation and hospital admissions. There's been multiple trials at telehealth monitoring, reviewing patients on the phone based on daily weights and self-reported symptoms. And they've all found to be ineffective at reducing hospital admissions. There's a number of reasons for this, but as you see in the next slides, the weight gain and development of symptoms is actually quite late into decompensation. And at that point, it's nearly too late to prevent the admission. As we can see here, up to 30 days before the hospitalization, we're starting to get hemodynamic changes that can be picked up by technology. And by the time we're getting to fluid accumulation and changes in weight and increase in symptom burden, we're starting to get to pre-symptomatic congestion, but it's still going to end up being congestion that needs medical intervention. And then if it gets to a crisis hospital admission, it starts a bit of a cascade of care there. So next slide, please, Helen. So a lot of the research we've done in the last year is about the development of an early warning system, essentially, for heart failure decompensation in the community. As I said there, we can detect a number of these issues up to 30 days before the hospital admission. You might be already coming across some of these early warning systems in your clinical practice. The implantable algorithms. So this is the HeartLogic multi-sensor by Boston Scientific. So it measures a number of parameters on ICDs and pacemakers that are already implanted. These are then wirelessly transmitted on the box the patients are carrying a pacemaker checks on anyway, and you're essentially getting a thoracic impedance or a level of the water in the chest, among other things, to flag that a patient is developing congestion and needs review and intervention. On the next slide, it just shows the parameters that these devices are measuring these days. So, heart sounds, S3 obviously being a sign of congestion, thoracic impedance again for congestion, respiration rate, activity, and heart rate. All these get fed into a proprietary algorithm, analyzed, and then it gives an index to say that this patient is at risk of decompensating and being decompensating and requiring intervention or hospital admission. So that's kind of what's on, I suppose, the most widespread technology in use at the moment. If we go on to the next slide, we can see some of the more emerging technologies. And again, these are all implantable technologies, not massively applicable for wide-scale adoption in rural communities unless they're already getting a device implanted. This is, I suppose, the gold standard in my eyes at the moment. It's the CARDIOmEMS implantable pulmonary artery pressure monitor. So this goes in a procedure in the cath lab. So again, quite invasive, but it does end up implanting a pressure device monitor in the pulmonary artery. This, they've shown, can actually show decompensation up to 30 days in advance. A lot of my facts and figures are in, I'll just get the exact numbers for you. But again, it shows that we're experiencing these, they did their trial. So it was the Monitor HF trial. Essentially, it was a prospective multi-center study with 25 participating sites in the Netherlands. This was just done in 2024. So it was 1/3 of all Dutch hospitals. So this trial was to evaluate the effectiveness of the remote hemodynamic monitoring on the quality of life and hospitalization rate. Significantly, this trial compared to previously trials done on the Boston Scientific and the CARDIOmEMS device, there was no increased clinician contact. So it's all well and good to say these device works, but if a doctor is checking it every day, it's not really applicable to our wide patient loads. So it showed a 44% reduction in heart failure hospitalizations, and patients showed a significant reduction in their mean pulmonary artery pressure at 12 months. So that's one of the mainstays at the moment in America that they're trying to roll out. But again, it's prohibitively expensive. You're talking about $50,000 between device fees, cath lab fees, physician fees to implant these things. So not really suitable for our health system. On the next slide, Helen, we have this. This is the Norm IVC device. So this is just in clinical trial phase at the moment. So Norm came out of FIRE1, a medical accelerator in California, but they've now moved to Ireland. Essentially what it is, it's a IVC diameter monitor. It's not a pressure monitor. It's monitoring the diameter of the IVC, and then gives an index and allows clinical decisions to be made off. So they produced a paper 2 years ago that says essentially the changes in the IVC have been found to represent a much more sensitive measure than pressure, because you get dilation before the pressure starts rising, for detecting underlying changes in intravascular volume and tone. There about 2 weeks ago, Norm actually just raised $120 million to further. They've only really done animal studies at the moment, but they have a clinical trial at the moment undergoing in Europe, where they're implanting it in about 50 patients. So that's one to watch for the future. A little less expensive than the CardioMEMS device, but again, it's an implantable, quite invasive, and probably not applicable to the wider patient population. So if we go on to the next slide, we can now see some of the more non-invasive solutions. The benefit with the non-invasive solutions, I suppose, are that they can be rolled out, but if you can get funding and get them integrated into current workflows in our practices, you can roll them out pretty quick. I'll go on to them in detail, but I'll just point out one or two here that I think are a little bit funny that I haven't gone into in detail. But essentially, this is a peripheral pulmonary edema monitor that literally just measures the diameter of the leg every day. They've got a couple million of funding for this. I'm not sure. I haven't dug into it. I don't think it's of any clinical benefit. On the next slide, we'll go into in detail on I believe it's the Zoll, or it might be the Readus, if you can show us the next slide. Excellent. So this is the remote dielectric sensing system by Readus. It's by Sensible Medical. So this is an Israeli company. So this device uses remote dielectric sensing, or radio waves, essentially, to assess for congestion in the lungs. So the technology was originally developed by the Israeli military to look through walls, but thankfully it's been repurposed for a bit more wholesome uses. So essentially, this device is used on discharge of a patient to check have they been adequately diuresed. It's obviously a point of care device. It's not something the patient would take home with them, like some of the other devices that I go into later on to monitor for decompensation at home. But they conducted a pilot study where patients who had been admitted with heart failure were randomized. On discharge, they were then assessed with the Readus device, and if they had significant congestion, once physicians had deemed them suitable for discharge, the Readus device would then trigger an additional review and further diuresis. Interestingly, it did find that up to 40% of patients were under diuresed at discharge. However, the extra diuresis and the extra clinician review actually had no effect on 30-day readmission rate or quality of life. So I suppose it shows in this space, not all that glitters is gold. This fancy technology, for all it looks like it would be a benefit, actually didn't have any benefit when they did their pilot study. There's more studies coming out, which I'm sure they'll find a way to make it look useful. If we go on to our next device, this is a much more promising system. So this is the Zoll heart failure management system. It's similar in a way. It uses radio frequency to assess for congestion in the lungs. It's a patch the patient gets sent home with and would wear for a couple of hours a day. So the Zoll system calculates it gives them a index based on the accumulation of fluid in their lungs. So they carried out a study where patients who were discharged from hospital within the previous 10 days and had a heart failure event in the previous 6 months were fitted with one of these devices. It then monitored them over the next 30, 60, 90 days, split them into an arm with normal treatment, as in weighing yourself, self-reporting symptoms, and having telehealth monitoring consultations. And then the study arm had the Zoll heart failure management system fitted. I think on the next slide here, Helen shows the results of that BMAD heart failure trial that just came out in 2024. And it had a 7% absolute risk reduction in 90-day readmission rates. and a 11.5% absolute risk reduction in 1 year readmission rates. With all these devices, I suppose you have to play the healthcare economics and look at the cost of an admission, which in Australia, you know, a readmission runs at about $11,000 to $15,000, I believe, at the moment for heart failure decompensation, versus the cost of the device and the extra physician contact that would be needed. So those are the two radiofrequency ablation or radiofrequency devices that are used for congestion. Another interesting one is the audio core device, which is on the next slide, I believe, Helen. So this is an interesting one in that it is an acoustic cardiography system. So it's listening to heart sounds, but also comparing it to the electrocardiology signals. Patient sticks it here a couple of times a day, essentially in the V3, V4 space. And it's not only just listening to the heart and comparing what they call cardioacoustic biomarkers, but also to the electromechanical activation time. So what an electromechanical activation time is essentially the amount of time it takes for the S1 to follow the QRS to see how well the heart's responding. So the strength of the S3 and the intensity and the persistence of the third heart sound is also assigned an index from 0 to 10. And if that index gets above 5, it's a sign of impending heart failure decompensation, and then it triggers a physician review. I think some of the results are on the next slide. If you go forward, Helen. So these are some of the results. Here we can see the electromechanical activation time from the start of the QRS to the start of the S1. Essentially, once it starts getting above 15%, the patients were deemed to be at higher risk of rehospitalization. Using this data, I suppose, in the same way that we should be using daily weights in consultation with their physicians. None of these are self-guided per se. They were able to tailor their therapy. You can see here that the patients who had an electromechanical activation time less than 15% obviously were doing much, much better at 90 days compared to those who had more than 15%. The cardioacoustic biomarker guided treatment reduced rehospitalizations markedly at about 60% after 1 year. As you can see, it's a non-invasive, not suitable for every patient, but obviously non-invasive, easily distributed and scaled given the size of it. So this is just emerging at the moment. I believe this study is from 2023, 2024. And then the next slide, please, Helen, is flying through these. I'm sorry, I'm losing some of my presenter points. So I'm preaching to the choir, I suppose, a bit with all these. I haven't delved too much into, you know, kind of systemic changes we could make because they're slow. They can't be scaled very quickly. And I'd be preaching to the choir a bit, given everyone here has extensive experience in all these. But essentially, the simple things tend to work as good as some of the technology. As we can see here, discharge counselling, home visits, liaisons with GPs, all these systemic changes we can make, and telephone follow-ups, education, they have a huge impact. So a systemic review of this multidisciplinary intervention done in 2023 showed that it had a 24% reduction in all-cause hospitalizations. And this was over a period of 55 months. So again, simple things do work. And again, the next slide as well, the cardiac rehabilitation. Exercise and cardiac rehabilitation is more effective than any of the high-tech solutions we discussed there, but again, you're all very familiar with this. Some of these systematic reviews on the Cochrane database shows that exercise and cardiac rehabilitation can reduce by 40 to 43% if we get funding and scale it, and reduces all-cause hospitalizations by 23 to 30%. So again, that was I suppose a quick overview of some of the emerging technologies in remote monitoring heart failure decompensation in the community. Apologies, I did lose my presenter notes, unfortunately, with technology issues. So I skipped over some of it, but if you have any questions. Again, I'll just The final slide is just the application link for Perth Biodesign, where you learn about all aspects of what it takes to take one of these devices from concept, identifying the problem, developing a concept, IP considerations, regulation considerations, design. There's mentors at every stage to walk you through it. And then finally, you know, grants and everything to help you bring it on to clinical trial and market. So if anyone is interested, happy to chat to them about it. They can scan this, and the two course directors, Ollie and Chloe, are also very available. Should you have any questions about the process. Thank you.
Thank you, Daire. That was very enlightening. Oh wow. Yeah. My camera's gone weird. It's gone all wide. I had no
lost Helen.
idea.
Has anyone got any questions?
Yeah, any questions? I haven't
you might be
seen
muted,
any
Helen.
in the chat. But Taylor, if you could unmute everybody, if you could put your hand up if you've got a question for Daire, please. Or just come off mute and ask Daire. I think that was absolutely fascinating. Really great for everyone in the room that the simple things work and that the exercise works. And yeah, and it's about the behavior change and getting people there. So often the readmission of these people, they are those frequent flyers. So maybe if they had the little audio cord device or something at home, then they could yeah, be found quicker. Someone's
Hi, it's Ailish Kaman here. Daire, with you know, I work in the outreach community service, and so we do all the home visiting and enact all the try to enact all the ways that you've described in those last couple of slides. But how soon would you see some of these devices being available for patients in the community and you know, and easily accessible for them? Because obviously some are still on trial at the moment, aren't they?
A lot of the ones I spoke about there are still on trial. The ones that the algorithm that the HeartLogic Boston Scientific thing was actually FDA approved in the last 18 months, I believe. So the congestion monitors have been around for actually a while, but that just gives thoracic impedance, which wasn't super accurate. And that actually is coming on the Boston Scientific pacemaker checks now. So, but it also depends who's following up on that and how often the patient's having a pacemaker check. And they haven't really been, I suppose, fully integrated into the workflows around the world as they have in America, where it's a much more privatized system and they're paying kind of a monthly fee for their cardiologist to monitor it. So that is actually out there at the moment and just, you know, isn't fully integrated. It's probably going to come more and more to Australia in the next couple of years as they make a better case for it. The things such as the audio core, again, from, I suppose, inception, clinical trial and everything, these devices can take anywhere from 5 to 7 years to come to market. Some of the other ones that I didn't delve into have just shown to not have a cost benefit, unfortunately, because they're prohibitively expensive. The likes of that CardioMEM system, you get amazing data off it and you're getting a very precise pulmonary artery pressure measurement. But it's no good to the vast majority of patients. No one's going to pay 50 grand for them to come in. We're limited by the number of cardiologists who can do the procedure. In terms of the non-invasive devices, such as the audio core, that's just coming on stream, I suppose, now in the next year or two or so. But again, likely quite expensive and unfortunately is probably very operator dependent. What I think you will see more of us in the next little while is there's a study out last year, the SCALE heart failure trial, and it's essentially a smart connected weighing scales. It measures like, I think 7 or 8 different parameters, not just, it's kind of seamlessly fits with the daily weight routine of the patient, but it's also measuring impedance or the resistance through the body to give an idea of congestion. It's measuring heart rate variability, all through their feet and hand probes. And that data, I suppose, that's something that I can see becoming much more useful in the community and probably integrated within the next year or two, rather than, you know, probably talking 4 or 5 years for most of the other things. The norm device, the implantable IVC monitor, it's only going into human trials now. It could be, you know, 4 or 5 years at least until that's commercially available, I'd say.
And I suppose it's having, as you said, having people at the other end getting all the data so that the data can be acted on in a timely manner. Yeah.
And a lot of devices as well, you know, they were just increasing the workload on the clinical teams. You're checking these. There's a lot of false positive readings. Now, to be fair to the HeartLogic device, one of their major selling points is that I think they only have like 2 false positive readings a year, is what they're touting at the moment. As well with the CardioMEMS, I think they had a quite low false positive reading. But I suppose the less invasive you get and the more easy these are to implement, then you're having a huge increase in their false positive rate. And then that's just increasing work on everyone in the community, unnecessarily reviewing these patients.
All right. Thanks, Daire.
Thanks. There's a question in the chat, Daire, while you're talking about the audio core and the less invasive devices. Kylie's asked, patients who are obese, is audio core effective?
Yeah, absolutely. Same as ultrasound. It works very similar to ultrasound. You're going to have a decrease in the accuracy of it. And unfortunately, a lot of our heart failure patients are elderly, are obese, aren't going to be able to find that rib space, aren't going to be able to get accurate data. And that's the problem with some of the non-invasive. That's what a lot of my research was in our device, was kind of work around a lot of these problems. I know it's unsatisfying. I can't say too much about it. I'd be murdered by my team. But we're trying to find a workaround for a lot of these things. We're essentially, the work we've been doing over the last year is really drilled in on making a device that's non-invasive, works for most patients, is easy to use, but is also implementable at a price point that, you know, you could implement it at scale. We're aiming for a price point of around $1,000, $1,500. And the idea is that patients would be given these on discharge from hospital in a similar fashion to how, you know, glucose monitors are distributed to diabetic patients. I suppose that's the niche we're trying to fill, and why I suppose in the end we won Biodesign. A lot of the problems I pointed out there with these devices, the technology is amazing. It is giving us actionable numbers, but only in certain patients, and only in patients who can afford it, and only in patients in systems who can deal with the extra data.
Yeah, kill them in 10 minutes. You can be more likely you'll manage.
Sorry, I missed that. I see Andrew Marana's got his hand up. Could you come off mute, Andrew?
Thanks, Helen. Great presentation, Daire. Really enjoyed it. Having dabbled a little bit in this space of remote monitoring in a research context, one of the challenges that we've always found, and you alluded to it before, was sort of integrating these new systems into routine clinical practice. And I guess along with that is the fact that, you know, there can be a lot of data generated, and it can be quite time consuming to filter through that data. I mean, do you see a role for AI in terms of sort of filtering the data and providing clinicians with sort of an easy sort of reference point for making clinical decisions with some of this remote monitoring technology?
Absolutely, especially with a lot of the algorithms that are coming out. It's really just trying to separate, I hate the phrase, but signal from noise. When you're getting buckets and buckets of data out of these, and the problem is with the regulations, there has to be a physician at the end of the decision chain. You don't want an AI making a decision saying, no, I think that's, you know, a false positive. You don't need to see your doctor. You don't need to go to hospital. We're not there yet with AI. But in terms of sifting through all the signal and maybe generating, you know, succinct reports that can be actioned by someone in the clinical team, you know, a heart failure nurse, the GP, a doctor, or even just, you know, it's definitely the way we're going. The major barrier to that, believe it or not, probably won't be whether or not the AI can do it. It'll be probably whether or not the regulators will allow it. Because especially with, you know, kind of the black box in thinking implemented by a lot of the AI models, if you can't show why a decision was made, you can't defend it in court. And then I suppose no physician is going to want to stake their reputation and their license on it. But it's definitely moving more and more that way. We just won't move as fast as other industries.
Thank you.
Yep. I think no harm in having all the steps in place first. Yeah. For the AI, some other questions from the room around any of the devices or the current clinical care that you provide. Please either pop in the chat or come off mute or raise your hand. Yeah? Oh, here we are. Helen Brooks, would you like to come off mute? Yep. Yeah, you had a question, Helen? No. We seem to be having a bit of tech trouble. There must be a coincidence there.
Yeah.
Yeah.
Apologies, a bit rushed. I skipped over some of the things I had to say because I lost my presenter notes with the technology troubles, but we got them.
And but Taylor has recorded the session, so, and you know, if we usually would send a link, so if you wanted to provide any extra information, you're most welcome to, because apologies for the tech not working so well when you started. So just going back to some of those more invasive, the norm 1 and the pulmonary artery pressure, I've forgotten the name of it. Are they used in Australia currently, or were they other countries?
So
Yeah.
the CardioMEMS is used in America. So they, again, the way their reimbursement system is set up really suits a device like this. So one of the major problems they've had with heart failure in America, kind of that they've really been targeting since about 2010, is their 30-day readmission rate for a heart failure admission. So their 30-day readmission rate was between 25 and 30%. And the way their reimbursement model works with insurance companies paying the hospitals or Medicaid paying the hospitals, they really started to get penalized. So there was large fines for the patient that got readmitted within 30 days. So there's really a space for devices like CardioMEMS at the moment, because, you know, if you can prevent 60% of your readmissions within 30 days with a CardioMEMS device, yes, it might be costing you $50,000, but you're going to bill the patient anyway, and then you're also not going to get fined by the insurance company. You're not going to get fined by Medicaid. That doesn't translate very well to Australia, because that's just not how our system works, which is probably why you won't see it here. Yeah, and for a good reason. But again, you won't see it there. The norm device apparently is going to be a little bit cheaper, and as per what they think on their pilot study, be a little bit more accurate. But it's just out of animal studies. They raised $120 million in January of this year to bring it to clinical trial phase. So that's just entering clinical trial phase at the moment in Europe. So that'll be interesting. But again, I suppose the ones we will realistically mostly see in Australia is the algorithms attached to devices that are already implanted, such as IC pacemakers. And again, I suppose the challenge will be just integrating that into, it won't be as hard on the private side, but on the public side, integrating it into workflows at the moment.
So yeah, it's more like adding it on to the existing device, but like the Boston Scientific
I suppose
pacemakers, etc.
Anecdotally, like I've seen these devices in practice. I've admitted patients and decompensated with heart failure through ED, and then you do their pacemaker check, and you're like, your device gave a congestion alert like 14 days ago, and here we are now. I'm sure they had no idea. They didn't get the report. No one was remotely monitoring their device. So we're kind of in a place where we have the data, but we don't know how to integrate it, know how to flag it, know how to deal with it.
for me, your slide that, you know, so if I've got heart failure and I'm starting to decompensate, it's days before, you know, so hemodynamically, you know, if you did my obs, etc., you'd find me back then, but I'm not doing anything about it because I'm not short of breath, I'm not using more pillows, I haven't got fat ankles yet. And so it's that intervening early that will stop the readmissions, yeah.
Absolutely. And I suppose prevention, as we said, with our vaccinations, our education,
Yeah.
all these things as well. And I suppose, even though I'm biased and I love the tech, and I suppose that's my background here, I can't preach too much on heart failure management. I'm sure everyone here knows much more than me about that. I suppose the takeaway at the end of it was actually the cheaper, more basic things ended up being much more
Yes.
much more effective than a lot of these expensive experimental technologies.
Yeah, I know lots of people in the room would have loved the last slide, especially Andrew, with the exercise and all the exercise physiologists and physios in the room would. Yeah, I also thought that the REDS machine, that was the point of care testing, so that was going to pick up 40% of people who were under diuresed.
Yeah.
Yeah.
So it was measuring. So what that was measuring, it was essentially giving a congestion level in the lungs at the time of discharge. So with that trial, the patients had already been reviewed and deemed fit for discharge. Then for the control arm, they were just sent home. For the study arm, they would then get this machine applied. It takes like a minute, gives you a number that's, you know, on a scale of 1 to 100, how congested are they? And then they would use that to make the clinical decision about whether or not they should get further review and diuresis. But the interesting thing was, so they'd already been deemed for discharge. The ones that were deemed to be still not adequately diuresed got more diuresis, but they didn't do any better. So the 30-day readmission rate was actually the same with that device. So it just goes to show some of this data, you know, isn't as useful as we would think it is, and it has to be applied in the correct setting.
Yeah. That's very interesting. So, and just before we wrap up, as Daire said, the Perth Biodesign, their application for the flagship program is open just now. And Chloe, who's one of the facilitators and directors there, has said if anyone wants to be in touch with her, you're most welcome to email me and I can put you in touch with her. But a great program. So yeah, I just saw a question up in the chat. How far away are you with CARDIOsure? How far from market is your CARDIOsure device?
About 5 years and $40 million. So I can send him my pay ID if he wants to invest. So one of the issues with development is the regulation considerations and the clinical trial phases. So you're talking from inception to market and there's different classes of medical devices. So like your class 1 is, you know, something simple like your you know, blood pressure cuff, your stethoscope. When you get up to a device like these that are monitoring a heart failure, it's a class 3 medical device and it gets very expensive very quickly. So what you'll see is a lot of these devices, they go through maybe 2-3 years of development, get an early pilot study done, and then they get bought out by, say, Boston Scientific or Abbott or one of the big device manufacturers who ultimately bring it to market. One of the systems there I talked about briefly was the Sentinel one. They started maybe 5 or 6 years ago. They only made it 4 years before, you know, you get bought out, which is unfortunately just because of the money involved, how it has to go these days.
I know at the beginning you spoke about the I want to call it VeinSure, but I've mixed it up. The device that detects the best vein for like paramedics and doctors. So is that now? It's on on the market?
I believe they're nearly at market. So they
Okay. Yeah.
and the other device, the continuous fetal lactate monitor, I
Yeah.
believe is going into manufacturing now and will be on market soon as well. And you know, they say they're going to replace CTG monitoring, so could be big news for WA.
Oh yes, CTG. I'm a midwife, and CTG monitoring has its own problems, doesn't it?
Reading tea leaves.
Yeah, especially with obesity, it's a definite factor in that one. So any last questions from the room? Otherwise, you're most welcome to be in touch with us. There will be a recording, and also if you could fill in the very quick, it's like a 3-question evaluation. I think, Taylor, we even have a $50 book voucher. So yes, please be first to fill it in. And I'd just like to thank you very much, Daire. What would we do without these people who really want to get in deep into all the workings and all the possibilities? So, and use all parts of your brain, the creative and the intellectual parts, to pull these devices together to help all our patients. So thanks everyone for attending, and thanks a lot, Daire.
Thank you, Helen.
Cheers. Okay, and yes, you will have access to